Hello everyone. So today we will be going over chest tubes. So if you are struggling to understand chest tubes, this video is a simplified way of understanding the use of chest tubes. All right, so the first thing to know is what is a chest tube for? So a chest tube is placed to remove air, fluid, or pus from a space around the lungs. This helps the lung expand properly and makes it easier to breathe. It's often used for conditions such as a collapsed lung, which is pneumothorax, a fluid buildup, pleural effusion, or infections. So the biggest takeaway from this slide is to know that the purpose of a chest tube is to remove air, fluid, or pus. So who would need a chest tube? So a patient who has a collapsed lung, which is a pneumothorax, which is air trapped in the chest cavity to pull that air out, right? If a patient had fluid buildup, excessive fluid around the lungs, or pleural effusion, we will want to use a chest tube to drain out all that extra fluid. If a patient has an infection, empyema, which is pus in the chest cavity, if the patient has been involved in any type of trauma, which is injury to the chest or the lungs, such as from an accident, or post-surgical to prevent fluid accumulation after lung or heart surgery. All right, so it is so important that you know the different parts of a chest tube, and that's what we will go over in the following slides, okay?
All right, so the first chamber I want to talk about is your suction control chamber. All right, so on the left side of the screen, we have your dry suction chamber. And then on the right side of the screen, we have your wet suction control chamber. So normally what you will see is you will see the dry suction one. So let's talk about that one first. So if you look over here, this is this area right here. So our dry suction, it is controlled by a dial on the side, and it is regulated by the suction monitor bellow, and that is below it, which is a orange accordion. And in this chamber right here, there is no water column. So all we would have to do, the chest tubes are normally set to -20. So we would just have to go to the side of the chest tube and turn it until it gets to -20. So when it talks about the suction bellow, which is right under it, let's say that your patient was ordered intermittent or continuous suction via wall suction, all that's part the suction bellow is doing is that the orange accordion will be pushed all the way out to that triangle, and that just means that the wall suctioning and the suctioning is actually working. So you always want to make sure that you look into that their suction bellow part just to make sure that your suction is working. But this is called dry suctioning. We're just controlling this by the dial that is on the side of the chest tube. All right, over here we have your wet suction. So you see, when we're comparing both chest tubes, we see that one has an extra column than the other, right? So this column right here is our wet suction chamber. So instead of dialing like we did on the dry suction to the appropriate suction amount, right here we would just fill up water. So you can't see on this one, so I would suggest that you look up these images so you can see a clearer picture. But you can see that on this the wet suction, it'll have numbers on it. It will have the same -20, -30, -40. And what you would do is you would just fill water up to the appropriate suction. So just remember, you have a dry suction. That's the one you're going to most commonly see. And you're going to do that with the dial. And then you have your water suction, which you're going to have not your water. Yeah, you got your wet suction, which you're going to have to fill up with water to the desired amount. Okay? So remember that if you do have a wet suction control, that water does evaporate over time. So you may need to add water to it. All right, so the next chamber we're going to talk about is our water seal chamber. So in order for us to have water in our water seal chamber, we have to add water in it. So there is a little port on the side, and normally on the back of the chest tubes, It will come with a little sterile water, and it comes with directions on how to add water to your water seal chamber. But don't worry about that. You will see all that in class, how you actually put together a chest tube. But it is important to know that in order for there to be water in the water seal chamber, you have to add the water, okay? So water is gonna be in this area. So let me highlight your water seal chamber. All right, so all of this is considered our water seal chamber. So what is the purpose of a water seal chamber? So it performs an underwater seal on the tube to allow air to be removed from the pleural space while preventing outside air from entering into the lungs. So in your water seal chamber, after we fill it up with water, right, there's going to be a little ball that sits right down here. So what are we going to be looking for in our water seal chamber? So it's going to be a little ball in this little skinny part, right? So I like to say there's a skinny part of our water seal chamber, and there's our big old wide part right there. But in the skinny part of your water seal chamber, there's going to be a little tiny ball in there. And it's going to be a ball sitting in water. And as the patient breathes in, that ball is going to rise. And as the patient breathes out, the ball is going to fall. So you're going to see a up and down, which we call titling as that patient breathes in and out. And that is going to happen in your water seal chamber. But in which part of, where are we actually going to be looking for this to happen at? You're going to see that ball in that little skinny part. So that is normal to see that ball rise and see that ball fall. Now, what happens if you don't see that ball rise and if you don't see that ball fall? You know, that could mean that the lungs have re-expanded, which is a good thing. So we would need to notify the doctor and then get a chest x-ray to confirm that. Or there could be some kink in the tubing. So we need to assess our tubing and get any kinks out, okay? So for this slide, we're just focusing on our water seal chamber. So remember, we should see a fluctuation of water, a titling when the patient breathes in, when the patient breathes out. And we're going to see it right here in this little skinny part, okay? In and out. So we should not see vigorous in our water seal chamber. We shouldn't see vigorous bubbling, right? Now, we may see intermittent bubbling, meaning a little bubble here, a little bubble there, if our patient has a pneumothorax, because what is a pneumothorax? A pneumothorax is air. So as they're pulling off that air out of the patient, then you may see intermittent bubbling in your water seal chamber, which is in this big part right here. You may see intermittent bubbling there, but you shouldn't see a bunch of bubbling. So you're like, Dr. Bonnet, where are we looking for our bubbling? We are looking for the bubbling in the wider part. So we're going to see bubbling in the wider part, and we should see titling in the skinny part of our chamber. Does that make sense? All right, in the next slide is going to go into a little bit more depth of the wider part of the water seal chamber. All right, so now in your water seal chamber, they have a compartment called the air leak monitor. So if you look right here, you see this little line? That is our air leak monitor. So what is the purpose of an air leak monitor? It helps track any air escaping from the pleural space into the drainage system. So if you see intermittent bubbling, it indicates that air is being drained, which is expected if the patient has a pneumothorax. So in this area, if we see intermittent bubbling, just like I talked about it, because remember, this is still the water seal chamber. So if we see intermittent bubbling in this big part, right, then that's expected if that patient has a pneumothorax. But if you see continuous, vigorous bubbling, that may suggest that this patient has an air leak, and we would need to do some further treatment. Now, when it comes to your air leak monitor, all right, so if you look on here, there are numbers on here, and there's like little dashes on here. So it lets you know, believe it starts at 0 and 1. So I think it goes to 1 to 5. So the greater the number, the bigger the air leak. So in our water seal chamber, we have an air leak monitor. So we want to think about it. Our air leak is in the big part, the wide part of our water sealed chamber. In our water sealed chamber, on the skinny part, we're going to see that little ball going up and down, up and down. But in this wide part, we should not see any continuous, vigorous bubbling. Now, we may see intermittent bubbling if the patient has a pneumothorax because we're sucking that air out of that area, right? But we shouldn't see continuous, vigorous bubbling here. That will suggest the air leak. And we want to look at our air leak monitor because it will actually tell us how big of the air leak that we actually have. So if you see absence of bubbling, then that is good. That could indicate that the air leak has been resolved.
All right, so the next compartment is compartment D. Circle it for you. And that's over here. So that is your drainage collection chamber. So that does what it says it does, is it drains. So your job as a nurse is to monitor the drainage. You want to look at the color, you want to look at the output, and you want to be aware that the patient should not have any more than 100 mLs of drainage per hour. So we want to keep up on how much the patient is draining. We want to look at the color and all that kind of stuff. So we want to make sure that we're keeping up with the patient's output, okay? All right, so what assessment should we be doing? So we should be assessing the lung sounds, breathing rate, and we should check for any difficulty breathing. We want to look for signs of worsening hemothorax or pneumothorax, all right? So we want to look for, is the patient actually getting better with this chest tube, or are they getting worse with this chest tube? So we want to examine the skin around the insertion site of the chest tube and look for any subcutaneous crepitus. And that is like if you go to where the chest tube is placed, that can show that it has carbon dioxide has escaped into the tissues. So when you press down on it, you can hear a crackling sensation. Sounds like little Rice Krispies. So we want to make sure that we are assessing around the chest tube site. Also, you want to encourage the patient to move by turning frequently, coughing, and taking deep breaths in to help clear fluid and improve lung function. So your assessment is always making sure that you are assessing your drainage, but also assessing the patient. Anytime that you a patient has any difficulty breathing, the first thing that you want to do is go to the patient, then go to the drainage system. We want to make sure that there's no kinks in the chest tube. We want to make sure that we let our patient know, like if that patient is hooked up to suction, hooked up to wall suction, then we want to let them know, like, hey, you should not be unplugging this to go to the restroom and things like that. So you want to teach your patient to, you know, not sit on the chest tube and all those types of things, to keep that chest tube unclamped, and tell them not to mess with the chest tube and don't pull it out and all those kind of things. So you want to make sure that you're assessing your patient, okay? All right, so some complications can happen when a patient has a chest tube. So when a chest tube becomes dislodged, that means that the hole that the tube went into, that is now out of the patient. So what do? Let's say the patient got up to go to the restroom and they forgot that they had a chest tube in. They do sometimes. And let's say they yanked at the tube and the whole tube came out, and now the tube is laying on the floor. So what you want to do is you want to cover that site with a sterile dressing, and you want to tape 3 sides. Why do you want to tape 3 sides? Because this allows air to escape and prevents a tension pneumothorax. And you want to notify the doctor immediately. So if the chest tube comes out of the patient completely, you want to cover the site with a sterile dressing and tape 3 sides. So what happens if the chest tube drainage system breaks? That means, let's say the patient knock over the chest tube system and it all breaks. What you want to do is you want to insert the tube 1 inch into a bottle of sterile water or sterile normal saline, and then obtain a new system. Then you'll be able to hook it back up to the new system. Now, the biggest thing for you to understand is when the chest tube system breaks, the tube is still inside the patient. So there's a difference between the tube being dislodged and the system breaks. So if the system breaks, that means that the tube is still inside of the patient, but the chest tube drainage system itself is broken. So just make sure you understand the difference between those two, okay? All right, really quick, just some things that you just want to keep in mind when dealing with the chest tubes. So we shouldn't be milking or stripping the tube like you can see in this picture. It's not recommended because it can create too much negative pressure. So let's say that you had some blood just sitting in the tube and it's not coming out fast like you want it. You can't go like this and milk the tube and strip the tube. You should not be doing that. Also, clamping the tube, that increases the risk of a patient developing a tension pneumothorax. So you should not be clamping your chest tubes unless you have an order from the physician, okay? All right, so when it comes to removing a chest tube, this is done by the physician unless you are at a hospital that you took a specific course for, you're certified to remove it. But for this class and for nursing in general, we're going to leave that to the physician. So once you get the physician order for it, you want to gather the supplies. Each physician is different for what they want, but the basic things that you all will need, you would need a suture removal kit, probably some hemostats, and you will need a occlusive gauze, okay? So you would need an occlusive gauze and your hemostats and your suture removal. All right, so you're just going to assist the physician with all this. Prior to removing the chest tube, you want to teach your patient how to do the Valsalva maneuver because we want to have that patient bear down, okay? You want to pre-medicate the patient if ordered because this can be painful and the patient needs to be in a semi-filus position. And while the physician is removing the tube, you want to monitor the patient's respiratory status. So knowing that you should expect that the patient should be sent to x-ray just to assess the lung re-expansion after removal.
A patient is receiving positive pressure mechanical ventilation and has a chest tube. When assessing the water sealed chamber, what do you expect to find? Is it A, water in the chamber will increase during inspiration and decrease during expiration? B, there will be continuous bubbling noted in the chamber? C, the water in the chamber will decrease during inspiration and increase during expiration? Or D, the water in the chamber will not move? I'll give you some time to think about it. So if you chose C, you are correct. So one thing that I didn't mention, which I will mention now, is that if a patient is on mechanical ventilation, the rising and the falling is going to switch. So if a patient has a chest tube and they're just on room air or they're just have nasal cannula, that ball is still going to rise when they breathe in and fall when they breathe out, right? But if the patient is intubated, meaning they're on mechanical ventilation, the water in the water sealed chamber will decrease when they breathing in and increase when they breathing out. So just remember, it's flipped if a patient is on mechanical ventilation.
You are assessing a patient who is post-op from a chest tube insertion. On assessment, you note there is 50 cc's of serous sanguineous fluid in the drainage chamber, fluctuation of the water in the water sealed chamber when the patient breathes in and out, and bubbling in the suction controlled chamber. Which of the following is most appropriate nursing intervention? Is it A, document your findings as normal, B, assess for an air leak due to bubbling noted in the suction chamber, C, notify the physician about the drainage, or D, milk the tubing to ensure the patency of the tube? All right, so if you chose A, document your findings as normal, you are correct. So all the things that were mentioned in this problem are normal things that are supposed to happen and are in normal ranges. A patient is about to have their chest tube removed by the physician. As the nurse assisting with the removal, which of the following actions will you perform? Select all that apply. Is it A, educate the patient how to take a deep breath out and inhale rapidly when the tube is being removed? B, gather supplies needed, which will include a petroleum gauze dressing per physician preference? C, place the patient in a semi-high filus position? D, have the patient take a deep breath, exhale, and bear down during the removal of the tube? E, pre-medicate the patient prior to removal as ordered by the physician? And F, place the patient in a prone position after removal. So I'm going to give you some time to think about it. So this is a select all that apply. So if you chose B, C, D, and E, you are correct. A patient is recovering from a pneumothorax and has a chest tube present. Which of the following is an appropriate finding when assessing the chest tube drainage system? Is it A, intermittent bubbling may be noted in the water seal chamber? B, 200 cc's of drainage per hour is expected during the recovery of a pneumothorax? C, the chest tube is positioned at the patient's chest level to facilitate drainage? Or D, all of these options are appropriate findings. So if you chose A, you are correct. So in the water seal chamber, if that patient has a pneumothorax, you will see intermittent bubbling. Why? Because it's sucking the air out of that pleural space and it's going into the drainage system. So you will see intermittent bubbling. The patient in room 2569 calls on the call light to tell you something is wrong with his chest tube. When you arrive to the room, you note that the drainage system has fallen on its side and is leaking drainage onto the floor from a crack in the system. What is your next priority? Is it A, place the patient in a supine position and clamp the tubing? B, notify the physician immediately? C, disconnect the drainage system and get a new one? Or D, disconnect the tubing from the drainage system and insert the tubing 1 inch in the bottle of sterile water and obtain a new system? All right, so give you some time to think about it. If you chose D, you are correct. So you want to disconnect the tubing from the old drainage system and then you want to insert the tubing into the 1 inch of sterile water and then get a new chest tube system. A patient with a chest tube has no fluctuation of water in the water seal chamber. What could be the cause of this? Is it A, this is an expected finding? B, the lungs may have re-expanded or there is a kink in the system? C, the system is broken and needs to be replaced? Or D, there is an air leak in the tubing? So if you chose B, you are correct. The lungs may have re-expanded or there is a kink in the system. While helping a patient with a chest tube reposition in the bed, the chest tube becomes dislodged. What is your immediate nursing intervention? Is it A, stay with the patient and monitor their vital signs while the other nurse notifies the physician? B, place a sterile dressing over the site and tape it on 3 sides and notify the physician? C, attempt to reinsert the tube? Or D, keep the site open to air and notify the physician? So if you chose B, you are correct. You want to place a sterile dressing over the site and tape it on 3 sides and notify the physician.